Esophageal carcinoma was well described at the beginning of the 19th century, and the first successful resection was performed in 1913 by Frank Turek. Esophageal carcinoma arises in the mucosa. Subsequently, it trends to invade the submucosa and the muscular layer, and eventually contagious structures such as the tracheobronchial tree, the aorta, or the recurrent laryngeal nerve. The tumor also tends to metastasize to the periesophageal lymph nodes and eventually to the liver, lungs, or both. The staging of the disease based on tumor invasion of the esophageal wall, T, involvement of lymph nodes, N, and the presence of metastasis, M. Cigarette smoking and alcohol may cause esophageal cancer, and the two may act synergistically in this regard. A high-fat diet and obesity may increase the risk of esophageal cancer. Other risk factors include achalasia and Plummer-Wilson syndrome. Gastroesophageal reflux disease is the most common predisposing factor for adenocarcinoma of the esophagus. Vitamin and nutritional deficiencies have been recognized as contributing factors. Dysphagia is the most common presenting symptom. Dysphagia is initially experienced for solids, but eventually progresses to include liquids. A complaint of dysphagia in an adult should always prompt an endoscopy to help rule out the presence of esophageal cancer. A barium swallow study is also indicated. Weight loss is the second most common symptom and occurs in more than 50% of people with esophageal carcinoma. Patients may experience bleeding. Pain can be felt in the epigastric or retrosternal area. It can also be felt over bony structures, representing a sign of metastatic disease. Hoarseness, caused by invasion of the recurrent laryngeal nerve, is a sign of unresectability. Patients may have a persistent cough. Respiratory symptoms can be caused by aspiration of undigested food or by direct invasion of the tracheobronchial tree by the tumor. The latter is also a sign of unresectability. Esophageal cancer is the seventh leading cause of cancer death worldwide. The incidence of esophageal carcinoma can be as high as 30 to 800 cases per 100,000 persons in particular areas of northern Iran, some areas of southern Russia, and northern China. In the United States, African Americans have a higher incidence of esophageal cancer than whites. Esophageal cancer is generally more common in men than in women, with a male to female ratio of 3 to 4 over 1. Esophageal cancer occurs most commonly during the 6th and 7th decades of life. The disease becomes more common with advancing age. It is about 20 times more common in those older than 65 years than in persons younger than 65 years. Regarding treatment for esophageal carcinoma, non-operative therapy is usually reserved for patients who have esophageal carcinoma and are not candidates for surgery. The goal of therapy for these patients is palliation of dysphagia, allowing them to eat. A single best method of palliation cannot be applied to every situation. Most patients require more than one palliative method to sustain lumen patency during the course of their disease. Esophageal resection, esophagectomy, remains a crucial part of the treatment of esophageal cancer. It is used in patients who are considered candidates for surgery. An esophagectomy can be performed by using an abdominal and a cervical incision with blunt mediastinal dissection through the esophageal hiatus, for instance transhiatal esophagectomy, THE, or by using an abdominal and right thoracic incision, for instance transthoracic esophagectomy, TTE. Approximately 85 to 90% of patients go home after discharge. The remaining patients may need additional time in a skilled nursing facility if they live alone and if they cannot take care of themselves. Patients are seen by the responsible surgeon at 2 weeks and 4 weeks after discharge from the hospital, and subsequently every 6 months by an oncologist. Most patients return to their regular level of activities within 2 months.